Welcome to this explainer. Have you ever looked at a hospital bill and felt like you were trying to read ancient hieroglyphs? Yeah, you're definitely not alone. But today, we're going to crack that code. We are translating the incredibly complex web of inpatient medical coding into the exact financial mechanics behind a hospital stay. Behind all those cryptic letters and numbers is a highly structured mathematical reality, and we're going to break it all down. Here is our roadmap for today. We'll start with the three coding systems, look at how procedure codes influence facility pay, break down what MS-DRGs actually are, walk through the assignment process, and finally calculate those inpatient payments. Let's get right into it.
Section 1. The three coding systems. Imagine you're lying in a hospital bed. Behind the scenes, there are actually two totally distinct financial engines running at the exact same time. First, the hospital facility itself is keeping track of its massive resource usage. Think the nursing staff, the bed, the surgical equipment, using a coding language called ICD-10-PCS. But the individual doctors checking on you, they report their specific professional labor using a completely different language, CPT codes, or current procedural terminology. So right out of the gate, we have two completely separate billing tracks for the exact same patient encounter.
But hey, they do have some common ground. Even with those completely different procedure codes, both the facility and your individual doctors unite under one universal language to declare the actual diagnosis. That language is ICD-10-CM. So whether the hospital is claiming the room cost or the surgeon is billing for operating time, they both have to use ICD-10-CM to basically say, hey, this patient has acute appendicitis. It's the unifying thread tying your whole medical narrative together.
Now, because these diagnosis codes are so absolutely crucial, they aren't just left to chance. They're rigorously maintained by a federal committee made up of folks from CMS and the National Center for Health Statistics. They actually hold public meetings every spring and fall to keep this HIPAA-designated code set totally up to date. They push out mid-year updates in April and then do major fiscal overhauls in October. And it's not just about getting paid, though. These codes literally drive national quality reviews, benchmarking, and vital health stats across the country.
All right, moving on to Section 2, Procedure Codes Influence Facility Pay.
We mentioned earlier that hospitals use ICD-10-PCS codes for all their nursing, supplies, and equipment. But here's the wild part. These codes don't actually slap a specific price tag on things. If a hospital uses a PCS code for an MRI, there's no master list out there saying that code equals exactly $500. No way. Instead, these highly specific codes figure out if a service is covered by insurance at all, and more importantly, they act as the primary drivers for a much larger automated grouping system.
So think of your procedure codes and your diagnosis codes as raw ingredients. The hospital doesn't just get paid piecemeal for every single bandage or hour of nursing time. Instead, all these detailed ICD-10-CM diagnosis codes and ICD-10-PCS procedure codes get tossed together into a massive software blender. The output? Your final payout category, known as a DRG.
Which brings us right to Section 3. What are MS-DRGs?
MS-DRG stands for Medicare Severity Diagnosis Related Group. This actually evolved from a 1983 system that was originally built to put the brakes on runaway fee-for-service costs and encourage efficiency. The modern version rolled out in 2008, and it basically categorizes clinically similar cases so insurers, and yes, that includes private insurers, not just Medicare, can pay a fixed predetermined rate. It essentially tells the hospital, look, based on the severity of this illness and the resources typically required, we're paying you this flat amount, period.
Let's break that down further in Section 4, the MS-DRG assignment process.
So how does the magic happen? Well, grouping software uses a super rigorous 4-step algorithmic formula to sort a patient's unique codes into one of about 800 final MS-DRG categories. First, it starts broad by identifying the general body system affected. Step 2, it splits based on whether the doctors did surgery or just provided medical treatment. Step 3 zeroes in on the specific principal diagnosis. And finally, Step 4 makes the ultimate division based on how severe the patient's illness actually is. Looking closely at Step 1, the system immediately drops the patient into one of 25 broad major diagnostic categories, or MDCs. Think of this like walking into a massive library and picking a specific floor. Having heart issues? You're going to the circulatory system floor, MDC 05. Having a baby? You're headed to the newborn floor, MDC 15. This MDC is the absolute starting point, the rigid foundation for the rest of that sorting algorithm. Now, skipping down to that final, critical step in the funnel, the software separates patients based on how incredibly sick they actually are. This is where clinical documentation is absolutely vital. The system basically asks, does this patient have an MCC, a major complication or comorbidity? Meaning, are they super sick and require massive additional resources? Or do they just have a standard CC? Or maybe they're presenting without any complicating factors at all. Let me tell you, this single distinction makes all the difference in the world.
And that perfectly sets up Section 5, calculating inpatient hospital payments.
Okay, the stark financial data right here reveals exactly why these codes matter so much. Take this heart failure example from NDC 5. The base condition is exactly the same across all 3 tiers, but simply documenting and coding a major complication, like, say, acute respiratory failure on top of the heart issues, legally shifts the hospital's reimbursement from an average of $4,100 all the way up to $9,300. The procedure and the primary diagnosis are exactly the same, but that severity modifier literally more than doubles the payment. Mind-blowing, right? Now, keep in mind, those table numbers are just national averages. To calculate the actual, real-world payout, you've got to use a specific mathematical formula. The hospital takes its predetermined facility base rate and multiplies it by the specific relative weight of the assigned MS-DRG. Basically, the relative weight represents the average resources required to treat patients in that group compared to the national average. So, an MS-DRG for a heart transplant is going to have a massive relative weight compared to, say, a standard bout of pneumonia.
But wait, the math doesn't stop there. That formula gets further adjusted to account for the reality on the ground. The final payout is tweaked based on patient factors like age, sex, and expected length of stay. And even more impactful are the facility adjustments. For example, a hospital in downtown Manhattan has a much higher cost of living and therefore a higher wage index than a rural hospital in Kansas, so their base rate is adjusted upwards. Hospitals that serve a high proportion of low-income patients or operate as teaching hospitals also get critical upward adjustments to their pay.
Which brings us to the absolute bottom line of this entire inpatient coding system: fixed financial risk. Remember, this is a prospective payment system. Hospitals are highly incentivized to be super efficient. If they can cure a patient and discharge them safely using fewer resources than the MS-DRG payout allows, the hospital retains the difference as profit. But on the flip side, if a patient stays 3 extra days and needs a bunch of extra tests, the hospital doesn't get a penny more. If care costs exceed the payout, they simply have to absorb the financial loss.
It's a system literally designed to control costs, but it leaves us with a fascinating and maybe slightly unsettling question to consider as we wrap up this explainer. If a hospital's financial survival depends on strictly matching patient care to a fixed algorithmic payout, how might this rigid, prospective coding system subtly shape the actual medical decisions being made? When we reduce human health into a series of strictly priced codes, do those codes merely reflect the medicine, or do they start to dictate it? Thanks so much for joining me today, and I'll catch you in the next one.